Oh, I was just going to say, everybody's so quiet. I feel like my audio is not working, but it is.
Good afternoon, everyone. Just wanted to say hello. I will be just listening in. Thank you.
Good afternoon.
I don't know if we have a sense of how many people are coming today.
I think there's a way in Teams to see who's accepted. How many have accepted?
I don't know if I didn't see that I had access to that.
And I don't know if I have that function either, Dr. Moss.
I think Peter would probably have that because I think he was the generator of the meeting invites.
Correct.
It looks like we have a lot of people. We can start whenever.
All right, Tony, and you want to start? You want me to start? Welcome. We're so glad everybody is here to begin the next steps on the Pediatric Hospice Working Group. So thank you for joining us today.
Am I on mute? Yes, I am. Yes, and I guess my question would be at this point, I'm assuming is it Dr. Moss and I that would actually convene these meetings and have to ask for a motion to do that? Because if that's the case, I think we kind of need to understand that a little bit.
May I jump in, Tony Ann and Carrie?
Yes, please.
Yes, thank you. Welcome, everyone. It's good to see you all. And I know Rep. Claritas Dietra and Senator Amar and I are here as members, but yes, we would leave it to you to actually run the meeting and take any necessary votes over time or to lead the discussion. We are here in support for you, but we turn it over to you and we look forward and are grateful for your leadership.
Okay, thank you. Thank you so much. So Dr. Moss, are you okay with me just going ahead and discussing our plan for some working sessions?
Sorry, I was on mute. Of course, yes.
Okay. Dr. Moss and I had a couple of conversations since our last meeting to try and figure out how we best handle and use everyone's time as efficiently as possible, because we know everyone on this call is extremely busy. So what is the best way for us to kind of phase out the things that need to be done? And what we thought would be first and foremost for us to put together a subgroup or just a working group smaller than this group to try and really determine the legislative and regulatory policies that may be causing barriers to pediatric hospice and providing pediatric hospice in the state. We think that if we can get that work done, which I think it could be quickly, we could then send out to the senators and representatives what it is we would really need help with from them, and then start doing the other work, which would be towards educating the community, towards the staffing that we need to start thinking about, the training that we need to start thinking about, how we move forward from there. But we were thinking that it probably would be best if we first tackle, because we do not want to waste the time of our, senators and representatives unless we have our pure facts and we completely understand that if we're saying a regulatory policy or a legislative policy is a barrier, that we have confirmed that. So, does that sound like, and I will go to you, Representative McCarthy Vahey, if you feel like that would be the best use for you all?
Thank you, Tony Ann. When we put forward this working group and others, always the goal is to hear from those who are on the ground, who are the experts who are doing this work, about what it is we need to do, or what we may need to do legislatively, or perhaps on the executive branch level, suggestions for how we can improve access to service and service. So that conversation can happen in any number of ways. I think you have a great group gathered here. So I hear what you're saying about, wanting to have some of those conversations offline, and that makes sense. But I also think this is the group assembled here is intended to help support some of those conversations. I'm not sure if I'm fully answering your question. I see Senator Amor on camera as well, and always welcome his thoughts as well as Rep. Claridis-Deetria.
Thank you, Representative McCarthy-Vahey. I completely agree with you. We want you to be the ones to guide us through the process, and we are going to look forward to getting the insights that you have. And some of those insights, or hopefully most of those insights, would become a law in future, hopefully. But there are some things that may need further conversation that we'll clarify, and we're just going to be hoping to learn from your conversations, the rationale for those. So thank you.
Okay, Zen, I would think that we would probably, and Kerry, stop me at any point if you want, but kind of decide on who can do some of this work offline. And it may be at different points. We're going to have some ad hoc members working with us on this. But then the thought was, I know we had decided to meet on a monthly basis. If we're not exactly ready next month, do you think that maybe we would also just present minutes from our working sessions until we actually have information to pass along to you at these meetings? And we're trying to determine if that feels like something we should do, or if we should just meet regularly every month with this whole group and just talk about where we're at, or what work we're doing outside of this.
So may I, Tony Ann, jump
Please.
in? So my thought and reaction to that is that if information is gathered, say for example, I'm seeing Carl Schissel's face on the screen, so I'm going to call him out. Say that a couple of you talk with Carl and talk with the Hospital Association to get his thoughts about process, and then come back to the group to hash that out and then, further enhance that. The intention would not be that each month you would come and report to us as legislators each month. The thought is that through the course of the month's meetings, you as a group would work through that process, and at the end of the process would then have some recommendations for us. I think it's always going to happen in these kinds of groups where you have conversations individually, because you have to gather information and come back to the group. But the wisdom of the group is partly why we've convened. And I think it gives you an opportunity to then not necessarily belabor a point, but really to gather the insight and input of the various perspectives of the people who are here.
Okay, and he is one of the people that we definitely want to have on a smaller group working towards this. I don't know, Dr. Moss, did you have anything else you wanted to say about what we discussed and trying to get some of this work done and then, meeting again?
So sure. So I was thinking about it, and I apologize, I've been on repeated service since we last spoke, but I was hoping to come up with a little bit of a mission statement that we could kind of go back to at the beginning of meetings, so we're all on the same page of what we're trying to do here. I think when you review the task at hand, much of the vernacular was about who is going to join us, and then there were some small tasks that were expected of us by March, or I guess hopeful tasks by March. Those are kind of separate than what we consider the low-hanging fruit, that are things that I personally think we as a group should think about. But the expectation or hope is that we would review existing hospice services for pediatric patients across the state, which Tracy's on here with me. We've been trying to do that effectively with the DPH committee for some time, really to hash out who's giving the services and where. So I think that's a priority for us, is to figure out really ultimately who is providing the care. Because we all have our thoughts and our groups that we utilize, but we really need that data point. We also are going to look for make recommendations for the appropriate levels of hospice services for patients. And then really important, third, is evaluating payment and funding options for pediatric hospice care. So I think those were the three pieces that were cited in the bill itself that came out to us. So I think we need to think about how we're going to meet those and what that looks like. And then in terms of what we had really talked about for the smaller things, is just really looking at how we could provide an increase in service by putting all these bright minds together in terms of pieces like pronouncement in the home, and talking about utilization of MOLST for kids. Right now, we don't really utilize the MOLST in the same way for pediatrics, even though it's a really thoughtful document. And then, the piece about bereavement. So I see it as two things. One is the charge that we've been asked to look at and report back to in March, and secondary is some of the other pieces that I think are small pieces that would really make a huge difference in our state, and that this group can really help to propel forward. Is what I'm saying make sense? I see Barbara's hand up, so I'll pause.
So, Tony Ann and Dr. Moss, I just wanted to piggyback, and forgive me if I'm being bold, but I just wanted to share some experiences that I've had on other work groups that I've been on. And similar, Dr. Moss, as to what you've just described, is how the subgroups that Tony Ann has mentioned have been actualized or operationalized, where we have taken apart the work or the mission of the group and broke those down into the work groups, and then had the work groups report back up to the larger committee. And those work groups are actually going to be critical, because they're going to help inform the legislature to the report. So I think, Dr. Moss, you characterized it perfectly. I think you know what the overarching points are that the group is charged with. And then I know, and again, Senator Anwar, Rep. McCarthy-Vahey, and Representative Clarida Stitra are going to be very interested in the report and the information that you gather from those subgroups. So thank you. And forgive me if I'm being bold with sharing other experiences.
No, we love you sharing other experiences. That's how, we want to just do this the best way we can. And so learning how, it's done, and that makes, so much sense to me, is that the subgroups would then just report up at, to the main meeting, right? Or the main group. So I think that's the best way to go. Do you agree, Kerry?
Yes.
Okay, so should we kind of take it where we have the 3 different points that were brought up and what the subgroups could look like, and who may want to be on what and would be the most helpful to be on the subgroup?
I think I agree that we should just address them as A, B, and C as they've been laid forth. I see Carl's hand is raised, so.
Yeah, I'd like to do a cross check at this point of the meeting. you know, our mission statement is set forth in section 29 of the Public Act. We've got till March 1st, 2025 to do three things. Dr. Moss recited what those things are. As I look at those three things, I don't see them as being separate and distinct. I see reviewing existing hospice services for pediatric patients across the state as an important kind of threshold inquiry. Once that's done, I think developing recommendations for appropriate levels of hospice to address gaps in the continuum, regional, whatever, you know, is sort of a secondary task. And then finally, and perhaps this can be consecutive, it ought to be, in my opinion, figuring out the payment and funding options, you know, is something that obviously we're going to need to confront because we all live in the real world and funding is usually very important. So I don't see these as separate and distinct. I see them somewhat related and almost, in the case of the first two, sequential. And I just wanted to share that sort of reaction as I studied the three tasks. And I'm also mindful of the clock. March 25th will be here before we know it. And we need to, and so what I do in working groups is kind of work backward. You know, March 1st is the day committee expects us to report. How do we work backward from a report or a set of recommendations? And what do we need to do to get that done? So thanks for letting me share those observations. I appreciate it.
So Dr. Moss, how would you, I keep going back to you because you were like I'm the Robin to your Batman. So just let me know like what, I mean, I think that's a good point. And I think everyone that is on this would probably be participating in all three steps, should we say, or all three charges. I think for me, trying to figure out how we do the work and report back to the group and not have maybe everybody be on every month, because I don't want to, you know, I want to be mindful of everyone's time. So the thought is then we would probably pick a good handful of people on this call today. I can kind of see who's on it, that we would need going forward and really just doing the work in getting these three steps done. Is that how you'd like to go forward, Carrie?
Yes, I was going to ask Tracy, since we've worked together, if you were charged today with to try and help navigate what the hospice services are that children are receiving in Connecticut, what is the resource that you feel that you would utilize in garnering that? Because that's been one of the biggest, I think, starting, if we're all looking at this, the point is A is where you start. And the question becomes, and I do think we need to expand, even though our charge is hospice, we need to expand it and to include palliative care and who perceives that they're providing palliative care, because that's going to change your numbers drastically, right? If you look at who's actually doing hospice, it's a very small number. Who's doing what we consider palliative care, it's a different number. But where would you stand in that data at this point today?
In the data or the collection of it?
No. What data do we have, existing data? Because we've tried over
it's anecdotal based on the membership to the association, and not all hospice providers are members of our association. So I'd be able to, I mean, I anecdotally, I know who's been doing some based on conversations. But I also know who's not doing it. And I believe that perhaps a survey is the way to capture that information. And
Tracy,
that probably would have to be administered. It would have to get created, and then I wouldn't be able to administer that unless you only want information from my members. It would probably need to come from, I mean, Barbara at DPH has the full list of licensed hospice providers. So perhaps an email can go out from this work group by DPH, or get the information from DPH to send it out with a request for them to complete a very simple survey with a deadline. And you may want to query them on if they do it, how many, if they don't do it, what are the challenges keeping them from doing it?
Right. And I think we have to be clear about who offers hospice versus who's providing hospice, because that's actually not the same distinction in
Correct.
pediatric care.
Yes.
And that's not the same who has experience with hospice versus who has interest in engagement versus who has training. Like to best understand what our state is offering, we have to ask this in many different ways. It's not just, are you a provider of hospice for children? Because we've done that, right? We know the answer to that. And I think Tracy, in all fairness, you answered it exactly the way I expected to, which is we've operated on anecdotal data, and that's actually probably quite accurate. I hate to say,
Yeah, it is.
But I think we need proof of that accuracy if we're really going to utilize this to step forward and ask for funding initiatives and other things to help with hospice. So I don't want to take too much time, so I appreciate you responding to that. Ross and Barbara, I'm sorry, I apologize. I don't know whose hand was up first.
Dr. Albert, you go ahead.
Thanks, and I apologize, I'm not on camera. I'm just not somewhere that I was able to today. I'm sorry. My question was whether, so I agree, my perception was that, to what Tracy said, that largely this will be anecdotal in, reaching out by email or discussing. I guess my question is, do we potentially have access to any claims data? Is there any way to assess Medicaid data, for example, since we're working within Connecticut, or are there any other market assessments that, again, potentially we might have access to try to get a sense, not just like Carrie described, not just of who offers it, but who's actually, maybe using billing as a way to use it as a surrogate marker for doing.
Hello, I'm Jasmine from Medicaid. I definitely think that's possible. We could look up some billing codes and see what comes up.
Certainly that doesn't capture private insurers, but at least it's more data than we have currently.
Yeah, may I also add to that, Jasmine? I think an area that probably is very gray, if you're looking at claims, you clearly could identify hospice billing claims, but I'm not so sure you'd be able to identify palliative care billing claims because it's not coded as palliative care. We do not have a Medicaid reimbursement specific to palliative care, so it would be captured under, some other method. It would be a home health Medicaid visit. It would not say palliative care. And we need to look specifically at home-based care, not facility-based.
Yep, I'll add that in as well to look.
Might be able to get something through, I don't know, Connecticut Community Health Network, the ASO, who has an intensive care management program, and they might capture those children under their intensive care management program. I'm not sure if they would or not.
Yeah, I know where to go, and
Okay.
I will be reaching out to them.
Great.
Get some of that data. Thank you.
I have to just bring up one thing that has always confused me, and maybe it's this group that kind of works this through a little bit further. I get confused between, not that I'm confused, but I feel like it's such a frustration between palliative care, palliative care, and pediatric hospice when we have concurrent care. And I think that's part of what makes me so frustrated, is that they can be on palliative care and they can get that one visit, and maybe, someone comes 3 weeks later, or, when they're in the home, because that's all like that palliative care calls for, as far as in the bill that I can see. But hospice, like, how do we bring that together so that even if, whatever we call it, whether it's palliative, comfort, like whatever, we should be allowed to provide these pediatric patients with the number of visits that hospice can provide, yet they're only allowed to have palliative care because hospice, they have to be certified for hospice. Like, I don't know if I'm even able to voice my frustration about palliative care and hospice, but it's almost like making a service that's totally different, but provides a good number of visits, because palliative care, hospice is palliative care when you have concurrent care.
So, Tony Ann, you brought up a critically important point that I think will need to be defined in the report. And I was going to speak to palliative care, where at DPH, we don't license, or it's not a credential that we license or certify at DPH, but rather we do credential hospice. But I think it's a critical point that you're raising that we need to distinguish in the report. And I don't want to jump ahead to March.
Right,
but
right.
If you, an expert, are having this, and I don't want to call it confusion, but this unsettledness about it and the lines, then I think we can be rest assured that individuals who don't work in this field every day need to have a good understanding
Exactly.
of that distinction.
Exactly. And what exactly, whatever this new thing would be, it would be the best for a pediatric patient to have as many visits as they can while they still have their shift nurses, while they're still obtaining all the services they can. That would be, I think, the most amazing thing for us. And like I said, that is way, we're like, that's way out there, and we have a lot of, low hanging fruit. But for me, that's like the ultimate. How do we provide this service for, concurrent care? They could be getting treatment, they could be prolonging their life, but we're still giving them the services that they need in the home. But I know I'm preaching to the choir here.
Right, but you identified one of the more important barriers, which is prognostication in pediatrics and concern of false prognostication for hospice benefit purposes, but recognition that sometimes that's the only service available, or the only way a company can take a patient on. And so it's a big issue that I'm not sure we can untie. If we just look at hospice, then we're really closing our eyes to a whole portion of children receiving hospice care. If we look at hospice designation, we're really not looking at children in the scope of hospice services in the state because of the requirements of designation. I think we have to be careful not to let vernacular dictate how we view this and what we do with this, because then we won't be serving the right population.
Right.
That is the crux, right? So, having concurrent care is a gift, but it's a blessing and a curse at times for families. And it's not universally, for those who don't do this every day, it's not a universal thing that everyone, we are supposed to provide concurrent care, but we know that that's not the reality for many of our patients. And we've discussed foregoing your home shift nurses, who are your family, your extended family, to provide a hospice type service for a patient is something that we've seen time and time. Parents have to make a choice. And that's just something that is, that's something that seems unconscionable when we think about it. And so we really need to get to a place where we figure out how that's not true in our state. Tracy, I'm sorry, I see your hand is up.
Yeah, that's okay. Thank you, Carrie. I have a few thoughts on this. One thing is, this whole discussion and the confusion within really needs to be outlined in the report that goes to the Public Health Committee. But I also wonder if it makes sense to invite guests to this work group. It would need to be soon, because as Carl mentioned, it's a good idea to backtrack when you have a due date, figure out what you need to get done and how quickly. But California has a program, and Massachusetts have programs, both of them. And perhaps we can have guests come in and speak about how they've implemented it. I know there's challenges in both, but it would be, I think, helpful to us to hear from those states in how they've managed the whole concurrent care piece. and just I think the overall programs, what they've done, what they might suggest to us, because we're going at it from what we know, and we don't know all that they've been through.
Does anyone have a contact? I mean, Massachusetts would probably be our best bet. I mean, one of our
I
board
have
members.
contacts at both, but
Okay.
I think these are virtual meetings, so I think we can, and they're at 3:30 in the afternoon, so it doesn't impact California time so much. If we can arrange to have speakers on both, and I probably can get that
I think that would
managed.
be great.
Yeah, and I also know someone from California and Massachusetts as well. So we can, between us, we should be able to get someone that can speak to us in the success. I know Massachusetts is incurring some challenges, but that's probably a very valuable lesson as well to hear from.
Yeah, but I think also they can do them on the same day. If you give them a time frame, so
Correct.
we want an hour of our meeting to be these two presentations total time.
Right. And I would suggest it would be the November meeting. I would want.
I was just going to say that. Can we shoot for the November meeting?
Should be able to.
That would be great.
So would be good at maybe, or we're still doing the second Wednesday of each month. So we're looking at November 13th as the next one. Is that correct?
Correct.
That's what
Peter, I wonder if you might be able to send out meeting invites to at least put these meetings on our calendars, so we don't all have to create our own.
I'll send them out. I'll be able to.
Perfect, thank you.
November 13th, and then it would be December 11th, January 8th, February 12th, and then March 12th for drinks to celebrate the submission. I'm just kidding.
Yes.
So essentially draft recommendations probably by the January 8th meeting, and final approval by the February 12th meeting.
In a perfect world, Tracy, yes.
Yes.
It doesn't dictate that you can't do more than, if you need to have another meeting, the work group doesn't, the legislation doesn't tell you how often you can meet. And I know you're trying to be very respectful of people's times, but I think as it gets into the crunch time, it's important to, really try to make sure we get it right.
And it's not that we don't respect everyone's time. It was just being more respectful of their time, because they actually don't need to be in on the actual working of it. So I think we can absolutely, so those are the dates that we'll all meet as a group, but we could be doing, work outside of these meetings and meeting. So I guess between Tracy and Kerry, we would wait to hear from you all if they could make it for the November 13th.
So Carrie, you and I probably need to just discuss offline, but just so you know, I'm going to contact the state association exec for Massachusetts and California.
Okay.
And ask them for who they would recommend to make a presentation on this topic, to give the reality side.
Right.
Not the perfect world side.
And but also the infrastructure side of how it functions, right? How do you function within your state to provide this?
Not to mention any insights on funding and sustainability. This better not be ARPA money.
I don't think it can be, Carl, can it?
Just kidding. No, you're right.
If it is, it's dream world.
That would be That would be great. I have, let me know, however you guys find who could possibly talk on November 13th. The only contact I have is one of our board members, knows the director of nursing for the Massachusetts, one of the hospices. She was actually part of the development of, I can reach out to him just to see if, she would be available to participate.
Why don't you send me that person's name if you would, Tony Ann, because if they're members of the Hospice Federation, that's what they call their association, then she would have a direct contact with that person and be able to, I'm hoping that the Hospice Federation of Massachusetts and the California Association can kind of look to their providers that have really
Right.
implemented and kind of gather the best options for speakers to present.
Okay.
But Dr. Moss, you started out in your initial comments with, I think you used the words mission statement. And would it make sense to just take a few minutes to maybe think about a mission statement or a problem that we are trying to define and solve through our report that will help to keep the group? This is a big issue. And
Right.
the three elements are just, while there are a large part of the issue, there are lots of microcosms related to this. And I think if we have a mission statement or a problem statement, it will help us stay focused. Because, Tony Ann, I had a little bit of tachycardia when you said we're only meeting November, December, January. It's like 4 meetings. 4 meetings. That's not a lot.
It's
So-
not a lot. I think I was just thinking about how everyone perceived, because I'm coming from a very different angle as a clinical physician on the floor that does a great deal of hospital work. And I think when I was looking at some of the charge of reviewing existing hospice services, I looked to my colleague Stephanie. We both need to figure out how many kids we're taking care of in the hospital because we can't get them home. Right. And what do those numbers look like? So there's data points that I think need to be included from our hospital services as well that are going to take some time to get together. So, and when we talk, the second point about the appropriate levels of hospice services for pediatric patients, I'm kind of wondering how other people interpret that statement and what that means to them. So I think when I was saying like really making sure that we're all very focused on, because I will admit, I just want to change the world. And I realize this isn't that. I just want to change the landscape of hospice care for pediatric patients for not just today, but forever. And I recognize that's much too much to want to do in the shortened time we have. So I'm very appreciative of anyone that reins me in on that, because I just want to make things better for these kids and these families. And there's just so much work to be done. But I think the start of trying to figure out how people interpret what our role really will be in doing this, I think that's going to be super helpful as other people interpret that as well.
And it will help keep us focused because
Right.
This is a complex issue.
It's complex and it's emotional, and that's those
Yes,
two. It's emotionally charged
absolutely.
and incredibly complicated, and therefore it makes for a lot of opportunity for discussion that doesn't always yield outcome. In all fairness, this is the world we live in. Those of us who do it. So I'm going to just ask people to throw out when they think about their role in this and what they think we should be doing in our short period of time. Does anyone have a thought they'd like to share? And I look to those of you who have done this before in a quick turnaround time, like
So because you have that painful pause, I always interject when it's there. And I think, Dr. Moss, about something that you said that was emotionally charged for me about 2 years ago. You described a situation where there was a child that wanted to die at home and they couldn't. So I think I see a problem that we have a problem with access to care for children who need end-of-life services. That's a part of the problem. And again, I'm not the subject matter expert. Tracy lives this world every day. So she may have other thoughts about it. And Dr. Moss and Tony Ann, this is your world. But you give me that moment for that painful pause, and I'm always going to interject something to keep the conversation moving. So access to services is a problem, the volume.
Right.
Well, it's access to services and the workforce trained to be able to provide those services. And the funding too, because the workforce training obviously needs to be a different level than for traditional adult hospice and palliative. And it's a calling, without a doubt. Hospice is a calling, period. But for pediatrics, it's a unique calling.
Well, I think as we approach hospice care and pediatrics, we need to remember how family-centered care is the dictum of pediatrics now, right? We round with families, we include families in every decision we make on their child, and how can we expect hospice to be anything less? But that's a different service in a home when you're taking care of a patient versus when you're taking care of an entire family taking care of a patient. And I think it's important to recognize that is how we provide pediatric care. I'm glad that's how we provide pediatric care in Connecticut, but it does change the way we look at hospice for adults and children.
Right, and then you add into it, on top of all of that, asking a parent who, when we have concurrent care, especially, who can have prolonging, life treatments and things, to sign a consent to come onto hospice saying that their child is going to die in 6 months or less. So it's, it's also that. I just wish it could be part of the care in a chronically ill child who may have a terminal illness. Like that's the barrier that we see. And then again, not having access is mainly because I don't know of any other hospice. I'm trying to think anywhere in our area that is providing pediatric hospice. They may say it on their website, but they are not providing pediatric hospice. So the access is, okay, what do we do even if all these things change? They have to start providing it. It needs to be part of hospice care, I think. Can't take care of the whole state with 3 or 4 hospices.
So I wonder, it's Russ. I wonder if framing this around access, though, would be a good starting point. And again, I don't want to impose it, but that question around, like, thinking about for those whose organizations do things like lean mentality, the sort of 5 whys. You keep saying why. If we start from the perspective of this is an access problem, and it almost then begs to explain the imperatives that we need to focus on. So the why, there's not enough staffing. The why, there's not the right funding in place or the legislation in place. I mean, I kind of, from my perspective, I think talking about access then funnels maybe the appropriate next questions to sort of create those subgroups and those sub initiatives.
So if we're really poised to ask the question of who is providing the care as the first step, the existing hospice services, and we're looking at that as a survey. What do we see as the best way to approach that survey? We can send it out to the places that are reportedly providing hospice care, but we know that that's not always, those aren't the groups. Like, we want to know what all of the pediatric home care, what they identify as hospice and end of life, and what they're calling that. So how do we think as a group that we can get that information back in an expedient manner that is usable?
So Carrie, it's Stephanie. I'm in between a couple of things. I apologize, but I think Ginny, when she was onboarded in the last 6 months as our care coordinator, actually did draft a list of the folks who provide pediatric hospice. And I believe she's expected to return to the States soon. So I'm happy to email her and ask her to give me the most updated version she has. And if you'd like to start with that, but I agree that you may query folks who say they do it. and they may still answer yes. And yet when you ask them to please provide service in home to support transition of care and goals of care, then they're not available. So I don't know how you get at the exact root of it. Because I just don't think folks are upfront honest about it. But I'm happy to share that list.
Yeah, I'm wondering if it's a twofold, like, do you provide it and when was the last time you provided it?
Well, was that
How many days,
Jasmine? Was Jasmine going to work on potentially through the billing, like who is actually billed for pediatric hospice cases?
Yep, I've already done that. I've already started.
So I think that would be the, who has actually billed a pediatric case? Because you're right, Stephanie, and it's like we all know that. Yeah, we provide pediatric hospice until you call. Then we're,
Well, I mean, I can say with certainty over the last 6 months to a year, we have partnered with 4 agencies successfully. So I don't know if that's your starting list, but that's 4.
Well,
That's
are we still going to take data from the places who may not be currently providing hospice care, but they did recently? Like if they had the staff, they did a case that maybe finished 6 months ago. Would we
Don't we
include it?
think it's important to get that information, because if they did, but they can't now, why?
Okay, yeah.
What are the challenges?
Yeah, that would be good. I agree.
Because it could be service area, it could be, lack of staff to cover,
Mhm.
could be a few things.
And can I also just offer up the idea that probably Stephanie and Carrie would probably have the best understanding also of if there are palliative care billing codes in addition to hospice billing. I recognize that there's not palliative care specific billing, but there are some diagnosis codes and other things that, again, not to get too far in the weeds, but that might be something that could be searchable in the, while we're looking for these claims. So that might offer up both hospice billing, but again, maybe a surrogate marker of some palliative care billing also.
Yeah, we try to utilize V codes with every patient we see in the hospital system for billing and tracking purposes.
Yeah, so that like V70 might be the sort of
Correct.
universal
That is-
palliative code.
V70 is what I use for every single patient I see, each time I see them.
I do as well.
and I think, I mean, when we know, I'm actually glad to hear that there's 4. But I think when we talk about if they're not doing it, why are they not doing it? I think we know most of I mean, I would like to hear if it's an anomaly other than you don't make enough money, you don't have the staffing, you have the staff, but you don't have anyone to train them. I think like those are most of the top things I have heard, because when we started somewhat of a committee, me and Dr. Moss and Dr. Massaro and Dr. Albert, I made a lot of phone calls and just said, just tell me why you don't. The number one reason for most was financial. And the next was, we don't have nurses that we're able to train in pediatric hospice. We don't have the expertise or the training ability. So I think I would be interested if there's some other anomaly that a reason why they don't do pediatric hospice. But if we can build, we're looking at, so regional's looking at trying to become a center of excellence for training in pediatric hospice. So that could be the answer to some things. But I also think, and I know I'm jumping ahead again, but I also think at some point, if you provide hospice, you provide hospice. That's like me saying, okay, regional hospice is going to provide hospice, but we don't do from 50 to 75-year-olds. It's like, it will have, in order to make access possible, I think it's just going to have to be part of that. Hospice is from 0 to however old.
I can explore at DPH if we can send out a survey through so we have electronic addresses for all of our home health agency providers. So I can explore at DPH if we can send the surveys out through that mechanism. Or I will tell you, in the past, during COVID, we did lots of nursing home surveys. And I created a survey in office.com and sent it through the blast fax, the link. And with the nursing home providers, we got a good response, and I suspect it would be the same for home health agencies as well. And we would capture then the entire universe of home health agencies. And I know, Tracy, most of the agencies are your members, but there is that small little subgroup that is not associated with it. So I could explore that if it's helpful.
Stephanie, when you were talking before, I believe Eileen didn't she do a survey now that we're talking about all this? I don't know what the questions were that she asked, but I could swear she did one maybe 2 years ago.
She did. I would have to go back to her to see what the data point outcome was for that, because I actually don't know. I know that that was, I don't know if it has all the information we're looking for, and I actually can't remember exactly what the results showed, but I can follow up with.
And maybe if it's at least a foundation and then we can, edit that instead of creating new.
I'm happy to follow up with Eileen and see where she stood on those data points. I think whatever we do, we have to do it in an expedient manner.
Yeah.
In terms of putting this together. And so there's 1,000 questions I'd like to ask, but maybe the most important are simplistically, are you doing this care? And how many patients have you served pediatric patients have you served in the last, 2 years or 5 years, whatever we want to look for. I think we're going to see a lot of zeros for the 5-year, to be honest. And then do you have interest in serving the patients, which is always the question, is if we had better resources, would our agency have interest? Interest and intention, I should say. It's not just interest, it's true intent. But Carl, you have your hand up, your turn.
Thank you. Yeah, no, thanks. I was waiting patiently because I hoped this discussion would, conclude. I wanted to raise a third question, and it kind of goes to our third charge. And this is a question born from ignorance. So I welcome your input on this. So the question is, do we have a sense of what the payer mix is for hospice services for pediatric patients? Is it commercial insurance, Medicaid, charity care unreimbursed, private pay? How does it break down? If it's mostly Medicaid, then maybe that Medicaid data will be, somewhat dispositive. But if it's a more robust mix, then we might have some additional work to do if we're going to try to get some meaningful data. Not to say starting with Medicaid isn't a great place to start, but the question to the experts: do y'all have a sense of where the payers are making their payment, or what percentage of your patients are Medicaid versus other forms of payment? Thanks.
We at regional, about 70% of ours are Medicaid.
Okay. And how about the balance, commercial insurance versus other things?
Commercial versus charity care.
Got it.
Mm-hmm.
Thanks.
Got that for Yale as well.
Great.
And I think that probably represents Connecticut Children's as well. So many of our children qualify for Husky so a lot of them have dual payers, and depending on what's being paid, so it gets a little tricky. But I think that we should just go with as much data as we can get from the Medicaid as representative for a lot of those patients.
And I would say consistent with Hartford also, just to chime in with everybody else.
So do you think it's roughly a 70-15-15 proposition, something like that? I mean, we're ballpark. This is lawyer math, so don't worry about it. But is that roughly kind of where we are with this in terms of the payer mix?
I think it's less. I think it's more. I would not, because most children are going to end up with Husky. Very few children aren't covered under Husky. Even children that have arrived here, we get them into Husky. So when we insure children of the state of Connecticut in a beautiful way. So I think I would not agree. I do not think it's 15-15. I think that's probably 20 versus 5, but I don't know, Tony, if you disagree.
No, I
From
would
charity
agree.
care.
I would agree.
Great. Thanks, I appreciate that.
Trying to see.
So I think we have some work to do to figure out what we know already, what we've already done and what we know before we then do our next steps, which is trying to survey and see what information we can get from all the agencies out there, and then utilize that to move to the next step in terms of making recommendations. Do others see it that way?
I agree.
Yes, and I've already reached out to Massachusetts and California, and I'll let you know regarding them being able to present.
Yes, and I sent separate email messages with links to the Massachusetts program, and we also
Yeah.
confirmed that it's funded with an appropriation.
Right.
From the Massachusetts state government.
And it has been for a good number of years now.
For as long as I've been doing it, it has been.
Thanks.
Mhm.
So it feels like a lot to wait till November for next steps.
I-
Mhm.
Yeah.
I don't know if we want to choose to be, forgive me, this is my first working group here in Connecticut. So just wondering if we wanted to think about meeting more frequently with less, like a shorter meeting time. As I know we were allotted 2 hours for today's meeting, but perhaps we could do an in-between meeting that's just a report out of where people are and where next steps are, just so communication stays intact.
Yeah, I think that makes a lot of sense.
Please join. I love that everyone's raising their hand. Meetings with doctors, people don't raise their hand; they just jump on. You all are very polite.
Well, thank you, Dr. Moss. And also sometimes with Zoom, if people start talking at the same time and because of CTN, we find it really helpful to use the raise hand function on these meetings just so that the public who's listening in can actually hear. That's one of the reasons why. But I want to just thank you for this conversation and just encourage you to meet at whatever op tempo that you feel is needed, knowing that you will need to coordinate with Peter and Beverly in terms of the timing for the Zooms, as we talked about last time. So I think that's something, if you want to, have an offline conversation and see if that op tempo can change a little bit to help facilitate the conversations, I think that's fine. It's just would probably be best to talk with them to make sure that we have the access to the Zoom and the YouTube channel.
Well, we also, and of course, I'm gonna have to get used to raising my hand, because like you, Carrie, it's like, okay, the thought is in my head, but we actually, Carrie, Stephanie, Ross, and myself will be meeting on October 16th, which is next Wednesday. That's probably kind of short notice, but maybe if we could at least discuss that do we have the people, maybe have they responded back by November? If Tracy, if we add you to that, maybe we could just do a quick check-in for that, or even just through an email, I guess, could be fine too.
Yeah, I'm not available on the 16th, but I think email and especially if you throw out like the questions for the survey, if you get that done, then in the meantime, we can solidify that and get Barbara to do a blast to the hospice providers with the link.
And potentially also that would give Tony and your team and my team an option we could look at our own claims data to answer that question of percentage wise of, Medicaid versus private versus other. So at least we could just look internally.
Mm-hmm. Okay. So looks like we have a pretty good idea of what we're doing for next steps, and just trying to work as quickly as possible.
Is there anyone else that has anything to add today?
So are we
Better hand
doing
up.
a survey or I was confused that, are we doing a survey or no?
I think we're doing a survey, but we were going to try and figure out what information we had before we go to the next step of sending it out. So I think by the meeting that we have scheduled upcoming, the four of us, that I'm hopefully that we will have some of that information, and also have information if we'll be able to be joined from California and Massachusetts.
So I'll start in doing some exploration here, what vehicle or pathway we will use. And if you need help setting the survey up in office.com, which is what we've used before, because of the functionality at the end, I'm happy to help and support that as well.
I would welcome that help. I can help skeleton what I think would be the important things to include in the survey.
Okay, that would be great. And I can get started on that right away.
Okay.
And then if that work starts now, Dr. Moss, I could have that ready for you to present, you and Tony and Dr. Albert next week.
Okay.
Great. Okay.
I just personally want to thank those of you who have done this before, that are really providing lovely guardrails for the naive one here that has not addressed this. I just have so many things I want to say and do, but thank you for providing some guardrails to help us get something accomplished. I always have to remind myself small bites are the way to get there, but
yes, I echo the same. Okay.
All right. Is there anyone else that would like to add before we ask for a motion to adjourn? Motion to adjourn our meeting. Tracy Woodach, second.
Okay.
Perfect. Thank you, Barbara. All right. It was so lovely seeing you guys. We'll look forward to a lot of progress before the holidays, and then back at it in the new year.
Yes.